neuromuscular, it might be an X-ray, but it's clinical. So each of those conditions that will make walking difficult is really important for you to do a good clinical exam. Okay? The second bit is really about attention to detail. One of my favorite stories in the Mahabharata, certain that you won't fail. Okay? So choosing the right patient, then what equipment do you need and how do you do it? Those are the three main parts of the talk. This is just a smorgasbord of all my revered teachers. You can see that they come from Jaipur, CMC, Chennai, Delhi, UK, USA. You know, I had such a privileged life because I had these friends from all over the world, and without their teaching me, I would not have been able to pass on to you today what I have learned. A small caveat, you know, this walking is every patient and their relative's dream. Mrinal was completely right. When we did a survey, we asked patients, paraplegic and tetraplegic, what would you like restored? And they, as he said, they said we want our autonomic function or our incontinence restored. You won't believe what was second. What was second? Not walking. Hand function was second. They said, no, at least we can eat, we can do something. Third was walking. So walking is not a high priority. But for most patients, that's the function that they miss immediately. And so it's their dream. And I think it's really important as a physician for you to make an accurate diagnosis of whether they will walk or not. So that's the story, the storyline. How do you choose who can be expected to walk, what equipment is required, how to train the patient, and what complications to watch out for. And if there's time, we do recent advances. Now, gait training is, the important thing is to accurately choose who you're going to spend time with. So I'm going to look at a dozen critical clinical determinants that will help predict walking potential. And now the most important thing is that they are all clinical. Okay? So of course the level of the lesion that's been done will go on. The age of the patient, it's important because older patients will have comorbidities which will affect cardiopulmonary function. Now a paraplegic will require something like 10 to 20 times the energy cost for walking that you and I require. So that's why the cardiopulmonary status has to be good. And you need to make sure that you are looking for these if they are there in their history, and examination. Concomitant brain injury is common. Cervical spine can go up to 40%. So 40% of patients, and the patient will not remember because they'll have amnesia. So you have to take an accurate history as they're brought up by the speakers who spoke before me. Chest injuries, 75% in dorsal spinal injuries. Okay? They may have chest injury, or they may have hemothorax, they may have ICU-associated atherosclerosis or pneumonias. So look for that, because if they have a severe respiratory distress or they have a compromise, then their walking will not be easy. Upper limb fractures. These are often missed, particularly in patients who've got a mild brachial plexus injury, or a fractured humerus, or a fractured distal radius. So these again make a difference, because if they've got if one hand is weak, somebody who's going to propel himself using his upper limbs is going to make a big compromise. Lower limb fractures, the ones that are usually missed are hip dislocations, fracture acetabulum, fracture pelvis, because if they have a T4 lesion, this is below the lesion, and the blood loss and the swelling is sometimes masked inside the abdomen. The abdomen is swollen, and you think it's part of the fracture, but it's part of the spinal fracture. So look out for these. And again, I'm repeating myself with intention. When you get a patient 1 month later, you may think that I don't have to examine the patient. It says that it's a T4 fracture, and the patient will not walk, or it's a T3 fracture, the patient will walk. Please examine it, and do it carefully, system by system. Pressure sores. In their walking, we're going to use hyperextension of the hip, and so if they've got pressure sores which compromise any of the tissues around the hip, it will make a big difference. Head-rock ossification, if you don't look at the range of motion as Dr. Singh described, you will miss a mild head-rock ossification. Similarly, uncontrolled spasticity, and of course, neuropathic pain, and don't forget to go for syringomyelia, as was described very well in the morning. there's often secondary osteoporosis, particularly patients will come to you 8 months, 9 months, 1 year after the injury, and then you have to be careful because they may have osteoporosis, particularly in the neck of the femur, neck of the hip joint, and that can cause a problem. And lastly, they may be depressed, and each of these, I just zipped through them in 3 minutes, but they're critical. If you can examine carefully for each of these, you'll find that you have a reason that you have to address. If you address, the patient may still walk, but if you ignore this, you'll find that the patient is not there. Now, what equipment is required? Now, this is again a huge portion. I can't make you jump across the ocean, but I'll give you a little boat. And I hope on that boat, using that boat, you can cross the ocean. Okay? So I don't use pelvic bands, HGOs and RGOs, mostly because we are not able to make them successful. We've tried making RGOs and HGOs. These are hip guidance and hip guidance orthosis and reciprocal gait orthosis, in which there's a spring or a tension wire in which when you flex the hip on one side, the cable is tension, and then it shortens and it makes it easier to flex the other side. Making it is complicated, and we've never succeeded making those in error. We don't use pelvic bands because when you put both the calipers and make them into one caliper, it becomes very heavy. Doffing, and walking becomes very, very difficult. So we tend to use HKFOs, and the important things to remember is that we tend to use different principles for different patients. So if you have an L, let's go down. If you have a paralysis below L5, what will be the motor loss? S1, 2, it's mainly plantar flexors and weakness in hip extensors. So you want to stop increased plantar flexion. Okay, I'm trying to keep you awake by asking you questions. Please, if you can answer them. I'm racing because I'm conscious of the lack of time. Okay. Now, if it was a L4 level, what would be the motor loss? Peroneal and plantar flexors. If it was L3, it would be your dorsiflexors also weak. So if only your plantar flexors are weak, you might be able to get away with an anterior AFO. If your ankle is weak completely, posterior and anterior, you need a solid ankle AFO, particularly if you have poor subtalar control. If you have motor power in one direction, you can try to give an articulated AFO, but generally for balance, I usually say start with a solid ankle AFO and then move to articulation if the patient improves or if his balance is better. If it's an L3 paralysis, or if it's an L3 level, they'll have some knee extensors. Okay? If it's an L1 level, they'll have some hip flexors, but it'll be very weak. Okay, an L3 person will have more hip flexors, L1 will have very weak. We found that up to T10, you can actually make them functional walkers with these HKFOs, with these, sorry, my mistake, with these bilateral KFOs. But the things to be careful about is how are you going to stabilize the hip? And we use the Scott-Craig principle to stabilize the hip. The Scott-Craig caliper has a marked, very definite dorsiflexion at the angle. So if you dorsiflex the angle, you put the patient is leaning forward, and to stop falling, he or she will lean backwards and use the ligament of Michello. Okay, it stretches this very strong ligament, Michello, that stops him from falling backwards. They have to use crutches. So now, how much dorsiflexion we usually decide by using the temporary caliper. Okay, you start in the therapy area, make them stand and see how much dorsiflexion they need. Okay, put a wedge under the heel so that they're leaning forward, and you will be able to estimate. And I usually go to the workshop and make sure that if we decided 7 degrees, it should be 7 degrees dorsiflexion, which means that you have to have a little wedge of 7 degrees on which the patient is made to sit. To sit and then put the foot on that wedge, so that you can exactly get a 7 degrees dorsiflexion of the ankle. It's usually a solid ankle AFO and padded so that you don't get pressure sores, and they may have a toe wedge to reduce spasticity. So these are all the options. You have to choose whether you need unilateral, bilateral, Indian AFO, and we always use a drop block knee joint. Occasionally from Alimco I'm able to get some offset knee joints, and if one side is got a little bit of knee excessive power, I might put an offset knee joint just to allow the flexion during swing of the knee to be a little easier. We need strong elbow crutches. We usually make them very cheaply with rods that are used for electrical wiring. You know, those metal rods. We use it with that because they last forever. They don't wear out. They don't break. But you have to be careful about the hand. The hand grip should be really padded so that you have as large an area of surface area for weight bearing as possible. Because if you don't, you get carpal tunnel, and because there's a lot of pressure on the median nerve and on the ulnar nerve as well in the Guyans canal. So if we wear up these compressions and make that really, very large, make the ferrule as soft as you can. Some things we learned, some of our patients go away and they stop working because they don't have a crutch ferrule or the ankle that is used to fit the AFO snugly in the shoe. And so we remember to give them spares or teach them how they can get all these spares from wherever they are. Okay, that's the end of it. I'll take one moment and then have questions. How to train the patient to walk? I put it in 4 steps. The first step is to do a cardio re-education program. The latissimus dorsi is very important. You put them into a device that can actually strengthen the latissimus dorsi, and you can start in a bed or prone trolley while the spinal fracture is still consolidated. Step 2, the beginning to stand, and it's mostly in parallel bars. Step 3 is by doing all this outside indoors and then subsequently outdoors. And step 4 is actually teaching them the functional independence with the calculus, because if they're not independent, they won't really use it. Step 5 is sports, athletics, etc. Now you might think that this is optional, but step 5 is as important as step 1. And here's a picture of some of our paraplegics participating in a race in CMC. The women always come first. And you can see she's a bit anxious, she's looking down, but the lady behind her is smiling and is actually a good functional walk. So this simple thing can work, and it's really important for you to believe in it. And I'll now take questions. The complications, you know, I listed them there. How to deal with them is well known. And recent advances, I'll leave the one slide there for recent advances, and this is actually more or less my last slide. Are there any questions? Okay, so either it's as clear as mud or a little bit of steep.
Sir, you start asking questions. We have understood everything.
Well, I have asked a question. Did you get anything out of this? Any questions? Have any of you tried?
You can all easy. You can ask the question. Those questions asked in the examination. Like, when you think the patient is ready to start the gait training? Gait training, though it's a very vague term. Gait training, I myself don't want to use this term gait training. Okay, but anything. When we can start? If gait training is a word, so they hate to use it. When to start? The patient is bedridden. Suppose T8 in a life. Okay. And this bowel and bladder involvement, pressure injury, okay, spasticity, and just bedridden. We have admitted it in our ward, and we are planning how to do it, sir. Ambulatory.
Yeah, you had a brilliant class on roads exam coming out with the mic. In the jungle. Which would you rather? Meet the tiger in the wild in the jungle when you're all alone on a dark night, or would you rather meet the tiger in the zoo? Sorry? Nobody wants to be in the zoo. This is the zoo, friends. This is the time to sort of say hello to the tiger, get to know him. Because when you meet him in the jungle, he'll be snapping your head off. Okay? So go on, make a mistake, it doesn't matter. You know, whenever I make a mistake, I give myself a star. Because in life I've learned much more from mistakes than from being right. So if you have any questions, do ask, otherwise my time is up. Thank you so much for this. I'm a dinosaur. and thank you for allowing this dinosaur to come back into circulation and to be with you. I really have enjoyed myself, and I'm sorry if I have not fulfilled your dream, but this is just the last slide. I want to point out that all that glitters is not gold. I looked up if Locomat and all these things are better than coronary therapy that you and I are able to do with our patients, and it's not. The evidence is that there's no evidence that these modern equipments are better. In fact, there is a disadvantage that they learn, they are made to walk passively. It's like watching movies. You don't always learn how to make a movie just by watching a movie because it's passive. They're not actively involved. But when there's a therapist or a person making them walk, that interaction is very important for the cerebral activity to enable you to learn. So that's all I have to say. It is possible for a person with spinal cord injuries to walk if you put yourself and teams in a patient with expertise, patience, and love. Thanks. Reflection. Certificate.
Okay.